Is Tom Chiller, who's the chief of the mycotic disease branch at the CDC. He's been a tremendous friend and collaborator for the MSG. And Tom is going to give us the pulse on what's happening in epidemiology in the mycotic world. And I'm guessing he's going to have a little bit of insight on what's happening specifically with Candida auris. Thank you, Tom.
Great, thanks. Thanks, Luis. Thanks for inviting me, and great to be a part of this group. Hard to follow two incredibly talented speakers and folks in this field, but I do realize after hearing them talk that I'm going to be in business for a while, because I'm looking at these biologics thinking we're in trouble as we move forward. So I'm going to talk to you a little bit about, just briefly about epidemiology, some of what David's already said a little bit, touch on resistance, and then focus more on Candida auris. My disclosure is that I'm a fun guy. Candida surveillance. So I'm focusing on our surveillance. We do surveillance now in 9 sites, covers about 18 million population. You can see here the states. This is part of a emerging infectious program that CDC has been running for a couple decades now. And if you look at candidemia incidence by year, and you can see here this is going almost 10 years now, you can see that that overall incidence is around 7 per 100,000, but there's some pretty good variation there that you can see. And so going from somewhere around 4 to up to 15 per 100,000, and the Baltimore area at one point had rates as high as like 26, 27. You can see that there's been a trend in the first few years of this surveillance where we only had a couple sites to go down, and subsequently it's really pretty stable, and we're not seeing a lot of changes. When you look at fluconazole resistance in somewhere around 8,000 isolates now, again, as David mentioned, resistance remains relatively low and relatively stable. Certainly in C. albicans, we see very, very little resistance overall in our sites to fluconazole. So that's, again, good news. And then looking overall again at echinocandin resistance, this is all species. You see it if you look all species specifically, it also remains relatively low, and you don't see a lot of trend there, at least in our surveillance. When you look more specifically at Candida glabrata, which is the bug we're more interested in, you can see a little bit more variation, but still rates relatively low, as David just mentioned. Clearly, as he also mentioned, individual sites see pretty high resistance, and so it begs the question about why are some places having more resistance than others? Is this something to do with stewardship? Is it something to do with the bugs and some of the resistance mechanisms that David described, et cetera? So we're still looking at that. So if you look overall at U.S. surveillance, as mentioned, although Candida albicans is still number 1, although Candida glabrata is sneaking up, and certainly in some hospitals Candida glabrata is number 1, resistance for fluconazole and albicans is still exceedingly low overall, and fluconazole resistance is somewhere around 7%. Echinocandin resistance in these species, the non-glabrata species, also remains exceedingly low. Candida glabrata, on the other hand, if we look at all glabrata isolates, we're about 1.1% were resistant to both fluconazole and echinocandin, so we're more of an MDR look. 28% of all echinocandin-resistant glabratas are flu-resistant, and 11% of flu-resistant glabratas are echinocandin-resistant. So again, this idea of that was just brought up of dual therapy, with seeing more and more MDR candidas, is concerning for sure. We also tried to estimate just recently. This actually I think is going to be a poster at ID Week from one of our fellows. The burden of candidemia using this EIP surveillance, and it's certainly not a perfect way to estimate, as you saw. Even though we have 17 million people under surveillance, that's just obviously a very small fraction of the total population, but we tried to extrapolate that out, and you can see here that we came up with numbers, somewhere in the 20,000s of candidemias with a mortality, if we use a mortality of around 26 then you can see that we have a number of deaths. And this, we tried to compare this with some of the other known infections and burden. And so you can sort of get at least a rough idea about where Candida compares. I think this number is probably low, but you know, it's moving towards some sort of estimates, which is at least helpful. And the new thing we're seeing, so just to give you new, because you all know all about candidemia, this is the new thing now. Proportion of infection drug user associated candidemia. And you can see here, these are the numbers in 2017. Some sites, this makes up a big proportion of their overall candidemias. You can see that we've had a couple states that have tripled in numbers. We all know the opioid problem and epidemic we're having in this country, and that focus is on that, curbing that epidemic, and certainly Candida is one of the bugs. I know that there are practices where you clean your needle with your mouth and then you inject it. So certainly a good way to introduce Candida into the bloodstream, and that's what we're seeing. You can see here that the rise in the Tennessee incidence we think is really due to the rise in IDU associated candidemias. And if you look at our overall surveillance now, 1 in 10 candidemias are associated with injection drug use in our 2017 data. This has really increased since 2014. And if you look at some of the differences, when we've just done a rough look at the data, obviously a much younger age group makes sense, right? A lot more hepatitis C, a lot less TPN associated candidemia, and you can see the in-hospital mortality is actually quite lower than the typical candidemia patient. So we're looking into this phenomena a lot more and trying to understand what this disease entity looks like. I wanted just to mention our antimicrobial resistance laboratory network that we started a couple years ago. This is a CDC network, and we fought really hard to make Candida part of this. It was initially the usual bacterial suspects. We got Candida included, and Candida auris helped sort of roll Candida into a core part of the pathogens that are now tested. And so we've been working with these labs, these 7 labs, to help them get up to speed on performing testing. And I think I had a couple slides here just to show you the objectives of this network with Candida was to set up this regional lab network for susceptibility testing so that it was a uniform practice to track resistance among Candida yeast species and identify emerging resistance like Candida auris. And if you take a look, this is what we tell labs to send. So this is directed mainly at state health labs, but then the state labs will tell their hospitals to send to them, et cetera. So we're not trying to do surveillance for all Candida. This is really focused on where we think the resistance is. So Candida glabrata, unidentifiable species, Candida auris, et cetera. And then just so far last year, the labs, and again, we're in the process of training them, tested about close to 500 isolates, so that's great. I mean, just a start. We imagine the capacity will increase dramatically. You can see certain labs were doing a lot more as they came on board than others, and this is just looking at the top 10 species. You can see because of Candida auris now, and because of the burden in New York and New Jersey, we are pushing some of these isolates and this testing out to these regional labs to support the states that are having major problems. You can see here some of the resistance. We had a couple isolates that were MDRs. And you can see here that the Candida auris made up 36% of all isolates, and 95% were identified correctly, although we do see some misidentified species coming in, and that's part of the educational process. So now I'll move quickly to give you a C. auris update. Who would have thought we'd be talking about a superbug that is a Candida? I think no one really thought this was coming. I still think that this paradigm shift is the most important thing to communicate. And when I'm talking about this with clinicians and others in the healthcare field, I say, don't think of this as a fungus. Think of it as a bacteria. It's acting just like a hospital-acquired Acinetobacter. It's acting a little bit like staph. It's acting like a bacteria where resistance is the norm. It loves skin, and it persists on skin now. We have patients with it on their skin for over a year. It loves contaminating surfaces and so therefore healthcare surfaces and facilities, and it spreads in these settings. And this is all nicely well documented, both here in the U.S. and globally on multiple fronts. So what does the epidemiology look like? Well, this back in 2015, this is probably around the time, or at least around the time I spoke with MSG first about it, when we started to get a small group together to try to understand it. You can see here that we knew it was in several countries, and of course now in 2018, it's in over 20, at least reported in over 20. Some of these countries are just one-off cases, which is good. But some of these countries have 40% of their candidemias, or at least some of the hospitals, that are now Candida auris. And in fact, talking to colleagues in South Africa, Nilesh Govender was telling me that it's the second most common candidemia cause in private hospitals in South Africa. So once it sort of takes hold and sets up shop, it can become a predominant species in causing invasive disease, and this is obviously what we're concerned about. Here's the U.S. look as of last month, I think up to somewhere over 400 clinical cases and 1,200 sort of colonized or screening cases, and I'll talk about that in a moment. You can see here that, again, it's New York, New Jersey, and Chicago, Illinois area that really make up the bulk of our epidemic. There have been one-off cases or two-off cases in other states, and you can see here on the map where those have occurred. For the most part, states have been incredibly aggressive in trying to tackle this bug and to try to control it. And in fact, New York has seen less cases over the past several months, and they have had a very aggressive stance and really trying to find the source of this, which it turns out is probably really incubating and spreading within these long-term acute care facilities. So hospitals, as we all know, do a pretty good job of infection control, and they're aggressive, but also patients are in and out rather quickly. These long-term ventilated care facilities, wow, I mean, they are just harbingers for not only Candida auris, but lots of other MDROs, and patients that come in and out of these facilities, back to hospitals, back to these facilities, back to hospitals, seem to be the real transmitters of not only Candida auris, but we think things like CRE and other things. And we're actually in the field with New York right now, and investigating, trying to understand risk factors in these long-term acute care for Candida auris. Just, look at our cases in the U.S., again, remains a very sick population, and so, well represented in these long-term acute care ventilated facilities, multiple underlying conditions, indwelling devices, et cetera. Again, extensively healthcare exposed, and have often other MDROs. So many of these patients with C. auris that are colonized with C. auris have multiple MDROs. We also know that healthcare abroad is a risk factor for C. auris. All of our cases resulted initially, at least, from an introduction from another country, and I'll show you the data on that in just a second. But so now we need to understand what that means to us and how we can identify as clinicians that where healthcare abroad is a risk. This looks at whole genome sequencing of somewhere around 700 to 800 isolates, and you can see that we know now that there are these 4 clades, and these clades are represent strains that have entered in the U.S., and so we know that we don't have our own homegrown clade yet. Maybe we will someday, but so far around the globe, every single isolate tracks back to one of these 4 clades, and you can see here that this is the data that we've done to look at where the isolates are occurring in the U.S. We also have well-documented travel-related cases. There are often these one-off cases, like in Connecticut, California, and Oklahoma, but because we can whole genome these isolates now, we can relate them directly back to an isolate from that country. And you can see here that these are just an example of 3 travel-related cases. David mentioned this a little bit, but just looking at the global resistance, I think we're now, I got this slide from Beth the other day, so up to 848 isolates tested. You can see here that echinocandin resistance, as mentioned, is there, but it remains still relatively low, which is good. Amphotericin in about a third, and of course, fluconazole resistance is quite universal amongst these isolates. It's interesting because it is clade or clone, or however you want to call this, specific. You can see here that there is some variation in the different clades. And I think important to note the East Asia clade, where the isolates, at least the earliest isolates, came from both Korea and Japan, 96 and 97. And when you talk to folks in Japan and Korea about their Candida auris, they say it's a benign, non-outbreak, non-epidemic disease. It's mainly of the ear. It doesn't invade as much. We don't see clusters. So this East Asia clade is clearly different, and I think we need to understand why it's a different bug. It's not an aggressively invasive organism. David also talked about the idea of resistance and how it can be acquired versus not intrinsic. We see that based on the patterns here for azoles in C. auris. When you look at MDR C. auris, which is really our concern, we now do have we have these pan-resistant isolates that are at least in 4 countries that I know of now. Just found out there was a couple in South Africa, which was concerning. So that's the bug that obviously classifies this as a superbug that we're very concerned about. You can still see here that MDR, though 2 or more, makes up a good 20% now of the isolates that we've been testing. And certainly some of them are pan-susceptible, but you can see that percentage is relatively low. I think the big news for us on the public health front is we're going to make this a nationally notifiable organism or infection, and that's good for us to help track it and figure out where it is and where we need to be aggressively attacking it. I think that the new phenomenon for us as mycologists is the idea that we have a fungal species that we have to worry about colonizing us. I mean, as already mentioned, we know that Candida is in our GI tract. It lives there. It's a healthy part of the microbiome for the most part. But this bug, we want to deal with colonization because we know colonization is a problem. And if you look at it, that patients remain, again, as I said, persistently colonized for weeks, months, year at least. I don't know years yet, but probably. You can see that there's a 60% 90-day mortality in these guys. We know that some, again, colonize for over a year. And I think in New York, they've classified only 16 to date as have cleared colonization by subsequent cultures. And there hasn't been a pattern to how they've been able to clear these people, so to speak. The other big thing about colonization that we know clearly that we didn't know before is that colonization can lead and is a risk factor for invasive disease. So we have at least 30 cases now of bloodstream infection from about 600 colonized patients in the New York area over the last couple of years. And clearly these colonized patients are a source for transmission to others. The most sensitive place to culture is the axilla and groin, although you can do nasal rectal swabs, you can find it there, but we do these combined axilla growing swabs, and then you can grow it in an enrichment media. It likes hotter temperatures and higher salt. The downside to this is that you have to wait. It used to be we'd say you had to wait 2 weeks to call it negative. I think we've reduced that down to 10 days or so. But still, if you're screening a patient and looking for colonization, you have to wait 10 days and you have to isolate that patient in theory. It's not the right way to go as far as a screening test. So the big question is, if we do develop a screening test, which I'll talk about in a second, when and who do we screen? This has been ramping up. Actually, contact tracing around a case is certainly where we've been doing most of it. We've been doing point prevalence surveys in places where we know that there's documented transmission. Admission screening is the big question, and that's now happening in several facilities in New York State. Screening of patients with a history of health care abroad, especially if they've had another MDRO like CPCRE. And then screening of patients in these high acuity long-term care facilities, again, especially if they've had another MDRO like CPCRE. These are the ways in which we're focusing on doing screening work right now. And the rapid diagnostics is going to be the key to the success of this. And David Perlin is involved in working on real-time PCR. The Wadsworth lab in New York has also developed a rapid real-time. There are companies like T2 that are out there doing stuff in this space. And again, this is the way we need to go, and we're in desperate need of a rapid diagnostic for screening, really, first, obviously for bloodstream as well. And my goal would be to have a diagnostic that tells you it's CORS, but then also tells you if it's resistant to azoles and echinocandins all at the same time. So we're hoping Perlin will develop that tomorrow. Decolonization or source control, this is the challenge. How do we do this? We don't, as mycologists, again, we don't deal with this. We're not thinking of decolonizing our patients. So chlorhexidine is like the universal agent now used everywhere. Is there some other topical thing we could use? How about antifungals? What about terbinafine? We give that, it gets incredibly high skin concentration. Should we be giving all these patients terbinafine for a week? Is that a possible answer? Removing, obviously, the pressure of antibiotics and antifungals, is that possible? And how about the Candida vaccine that's out there? We've talked to Jack Edwards and them about could we use this Candida vaccine to slow transmission or decolonize people. When the folks in England who were dealing with this first looked at chlorhexidine in vitro, actually the data looked okay, but there really hasn't been anything done in vivo, and facilities that have been using chlorhexidine haven't really claimed that it was a real success story for decolonizing folks, even with aggressive chlorhexidine bathing, et cetera. The other problem is just getting this out of the environment. You can see it can be found pretty much anywhere. We've had recent reports where it was on the head of these thermometers. They actually had to cut them off to stop transmission in an Oxford hospital. It's been found on shoes, on the floor, on instruments, even on hand dispensers to clean. So it gets everywhere. I think that the holy water of hospital disinfection, which are quaternary ammoniums, don't work. So that's what's used uniformly in all of our healthcare facilities. That doesn't work, so we've been pushing this C. diff sporicidal agents, but you can't pour 10% bleach on everything in your hospital, including the patients. If you could, that would be great, because then we would kill it. But unfortunately, we need to be thinking of other ways to environmentally disinfect. Hydrogen peroxide has looked promising in vitro, but we need some more real-world experience with it. UV light, I know they're using these UV robots in South Africa. There is some evidence to suggest that maybe really long-term UV exposure might be beneficial, but again, there's no real data, and we're hoping South Africa will tell us a little bit more. What products to actually use is still a big question out there, and again, this is not an area that we in mycology work on a lot, so this is a new area that we're going into and trying to learn about, but when do we use it, et cetera. So the challenges, I think, for CORS, as I look off in the future, are screening, colonization testing, is not widely available yet. Culture testing takes 10 days. We need these rapid diagnostics. They're being developed. We're using them certainly in New York. They're not widely available, but we're rolling them out. We're at least rolling a PCR, real-time PCR out into the ARLN labs probably this week or next. So ARLN labs will have the ability to take screening cultures and test them with a PCR. We need these decolonization methods. We're hoping that maybe someone here in the room will get excited about trying to decolonize CORS patients and design some studies. And then, of course, as I mentioned, environmental disinfection. So to end, where did this thing come from? Well, Brendan Jackson, who's somewhere in the room here, Brendan, stand up so they get to know you. Brendan heads our EPI team at CDC, so please approach him at this meeting. If you need money, studies, anything, he can give it to you. No, I'm just joking. So, I want you to meet Brendan, though. But he has been banging his head against the wall trying to figure out where CORS came from. And I'm not going to go into a lot of his theories because they're really cool, so if you get a chance to talk to him. But I think part of it rests on this idea that, fungi, as John Taylor will tell us, 1.5 to 6 million species, depending on who you believe. Their estimates of they've been around a lot longer than we have. Only a few hundred are pathogenic. There's probably a few thousand more that will become pathogenic in our lifetimes. And we got to live in balance with these. And so I think one of the thoughts here is this incredible amount of altering the environment that we do, and fungi are these environmental organisms. And one of the things that's been intriguing and striking to us is the use of triazoles in agriculture. And you can see here the first graph is sort of a global look from the Food Agriculture Organization, but then the second graph is U.S. data, our own data, and look at the last decade about how triazole use, and these are triazoles that are completely the same as our azoles that we use in humans, but they're used on plants. Look at how that use has really dramatically gone up. So it makes you wonder what's happening in the environment, since we know these organisms are coming from the environment. And finally, my shameless plug for Fungal Disease Awareness Week. This is our second year. It's next week, so we want you all to get out and talk fungus with people next week while you're at ID Week or while you're back at your institution. Thanks. There's a lot of people to acknowledge, so I'm just going to show a picture of our group and say thanks very much for your time and attention.
So we have about 5 minutes for questions for Tom. Dr. Rex.
John Rex from F2G. Thanks both to Tom and to David for their talks. What is being done at the global level to communicate these data, to the political leadership that needs to understand it to move it along? Fungi, to my ear, are not prominently displayed in the global surveillance summary information. There was a workshop recently in Lisbon, talked about surveillance programs and trying to get integrated. And so bacteria, great. Fungi, not so much to my ear. And I think that it's nice for us to talk to ourselves about Candida. That doesn't move the needle when you actually want to see change occur at a global level. So what are you doing? What's CDC doing? And what should MSG be doing to advocate in this space?
Yeah, that's a good question, and we don't have the time to address it all, but I will tell you that, I think my day job is not advocating to people like you, but is actually out there trying to advocate to stakeholders and people that fund organizations and folks that look at surveillance and prioritize what pathogens are important in the US and abroad. And so we are working on that constantly at CDC. And I certainly feel like that's my main purpose, is to talk about fungi and try to prioritize them and work with folks that are dealing with those sort of priorities. WHO has no fungal people, in their entire organization. So one of the things I've been trying to do is work a lot more with WHO, get them more interested in fungi. Could we get a mycologist in this room stationed at WHO for a couple of years? There are 3 major areas that they're interested in and they're embracing, and one is AMR, and Candida auris Candida is now going to be included in their global antimicrobial surveillance system. We're piloting that within what's called GLASS, which is WHO surveillance. It's going to be in their reports in the next couple of years. Good. Mycetoma and now chromoblastomycosis are neglected tropical diseases. They're finally NTDs. We finally have an NTD. So we're pushing the NTD group at WHO and abroad. In fact, we have an epidemiologist right now in Ethiopia working with the neglected tropical disease folks to find out how we can talk more about fungus. How can we get fungus in that mix? And then finally, of course, there's the whole HIV field and OIs and screening for crypto. Histoplasmosis, we just published a recent paper looking at the burden of histo in Latin America, showing it's probably as much as TB. And so we are working on those fronts, John. I mean, it's as you said, I feel like that's my job, and it's an uphill battle every day trying to advocate for these things. But I think we're making some progress. I think today or yesterday, the UN, as you know, the UN General Assembly is meeting. We actually held an event that Secretary Azar, Secretary of HHS, announced that we have this AMR challenge, and as part of that challenge, we made sure that fungi were front and center. I know several companies were at that event, and Jack Edwards was actually at that event, and so fungi were in that mix. It was really a bacterial and fungus event for AMR and the challenge, which I think is good. So we are working hard behind the scenes and in front of the scenes to try to keep fungi relevant. And as I said, these biologics, we need to start doing, biologic surveillance within our surveillance systems now to understand those risks. These infections, we don't see them decreasing. If anything, they're stable or increasing, and we get more new outbreaks and species, every month reported to us at the CDC. So yeah, that's my short-winded, long-winded answer to your question. But we can talk about that. So what could MSG do? That's another discussion. I think MSG has an important role to play, and I'd love to talk to more people about that.
Yeah, so that's a thought for Pete and Luis, that Candida auris might be the crisis that is needed to allow fungi to surface in the antibacterial conversations. They've sort of dragged along. They've been in there. They're in GAIN. They're in LPAD. But it's not been as strong as it could be, and a group like MSG can actually move the needle.
I agree.
Thank you.